Thank you for listening to my Grand Rounds presentation by Serenity Patterson. For my elective rotation, I was at the Maven Group with Dr. Lysette for Women's Health. There's a Rialto clinic as well as surgery component at St. Bernardine's Hospital. The purpose of this rotation was to provide focused training in women's health, including prenatal care, gynecological evaluations, inpatient and outpatient surgery, and management of common and high-risk conditions. So I was able to assist and help with prenatal visits, including obtaining obstetric history, performing fundal height measurements, getting fetal heart rate, ensuring and providing patient counseling on pregnancy and postpartum care, as well as gynecological visits, including routine exams, contraceptive counseling, pap smears, breast exams, vaginal cultures, management of abnormal bleeding, infections, and evaluation of gynecological complaints. I was able to observe procedures such as colposcopies, endometrial biopsies, IUD insertions, and Nexplanon insertions. For the inpatient care and surgical experience, I was able to participate in obstetric procedures, including vaginal deliveries and C-sections, assist in surgeries such as robotic-assisted total hysterectomies, tubal ligations, and myomectomies, and I was able to observe and assist in perioperative, preoperative, and intraoperative support, and as well as postoperative follow-up. So for this patient, for the HPI, we have a chief complaint of increased urination for 2 weeks. We have a 33-year-old G2P1 who presents for a routine 28-week gestation visit with increased urination. Patient reports polyuria and polydipsia that began 2 weeks ago. She was consulted regarding her symptoms and provided a lab sip for oral glucose tolerance test during her last appointment, which she has completed and will be reviewed at today's visit. Patient reports symptoms have been present for 2 weeks, continuous throughout the day. She reports nothing she does improves or worsens her symptoms. She denies vaginal bleeding, pain, dysuria, flank pain, fever, nausea, vomiting, vision changes or headaches, vaginal bleeding, or abnormal discharge. Her vitals are normal with a BP of 124/78, heart rate of 82, and a weight of 158, fundal height measuring 28, and a fetal heart rate of 135, which is within normal limits. She has a past medical history of iron deficiency anemia, which she's taking an iron supplement, one tablet orally once daily, as well as a 28-week gestation pregnancy, which she's taking a daily prenatal tablet orally once daily. She denies any PCS, diabetes, hypertension, uterine fibroids, depression, breast cancer, or cervical cancer, or any type of bleeding dyscrasias, and denies childhood illnesses. Her surgical history is non-contributory with an appendectomy in 2015 with no complications, as well as a C-section in 2011 with no complications, with the male being born of 6 pounds and 2 ounces. She has no recent hospitalizations and her immunizations are up to date. Her last pap smear was March of 2024, which was within normal limits and no signs of HPV or cervical cancer changes. She has no allergies to food or latex. She's compliant with her medication and reports no prescription medications, use of pre-workout or caffeine pills. Her family history is non-contributing with no history of diabetes, autism, heart disease, hypertension, cervical cancer or breast cancer or PCOS. Her mother does have hyperthyroidism and her father does have chronic gout. She reports that she walks around for work but has no other outside exercise. She currently works as a third grade teacher. She does also report that she does not monitor her diet and it includes fast food, juice, or microwave foods. She currently is not sexually active and she is married and lives with her husband. She reports no use of alcohol, illicit drugs, marijuana, or tobacco. She has a bachelor's degree in education. She reports she's able to maintain and provide for herself financially. She has good family and community support. She lives in a safe neighborhood with access to healthcare and essential services and no transportation barriers. She's also aware of and has access to WIC and community programs. Her review of systems, she denies fever, chills, or night sweats, denies SI or HI, depression or anxiety. She denies wheezing, cough, shortness of breath, or rapid breathing. She denies chest pain, palpitations, or edema. She also denies dysuria, hematuria, or flank pain, but she does report frequent urination. She also reports increased thirst, but denies heat or cold intolerance, unexpected weight loss or gain, or hair loss. She denies nausea, vomiting, abdominal pain or cramping, constipation, diarrhea, or hematochezia. She also denies nausea, vision changes, blurry vision, dizziness, syncope, weakness, numbness, or tingling. And she also denies rash, lesions, hyperpigmentation, or pruritus, and denies any vaginal bleeding, leaking of fluid, vaginal lesions, abnormal discharge, vaginal pruritus, and denies any nipple changes or breast skin changes. On physical exam, she's well appearing, well hydrated, and no acute distress, A and O times 4. She's a normal mood and affect, and she has a normal rate and rhythm for her cardiac exam, no murmurs, rubs, or heaves. She also has a radial pulse of 2 plus bilaterally and absence of peripheral edema. Her lungs are clear to auscultation bilaterally without wheezes or crackles and no use of accessory muscles. Her skin is warm and intact in absence of rashes, hyperpigmentation, pustules, or papules. Her abdomen is enlarged with a fundal height measuring of 28 centimeters, which is consistent with her gestational age, and a fetal heart rate of 135. There's no guarding or localized tenderness with light abdominal palpation, and there's absence of CVA tenderness. There is a normal gynecological exam with normal appearing perineum, labia majora minora, absence of vaginal lesions or masses. Her cervical os is closed with 0 centimeters dilated cervix with 0% effacement. There's no abnormal discharge, foul odor, or vaginal blood observed in the vaginal vault. So these are her diagnostic studies, and they will be assessed in the assessment. So we have a 33-year-old G2 P1 who's 28 weeks gestation, presenting with polyuria and polydipsia for 2 weeks. She reports symptoms are continuous throughout the day, generalized, and nothing she does alleviates or relieves or aggravates her symptoms. The patient denies dysuria, flank pain, abdominal pain, blurry vision, headache, edema, abnormal vaginal discharge or hematuria. On physical exam, abdomen is enlarged with a fundal height of 28, consistent with gestational age, and a fetal heart rate of 135. No guarding or localized tenderness observed. Absent CVA tenderness, normal appearing perineum, labia majora and minora, absence of vaginal lesions or masses, no abnormal discharge, foul odor, or vaginal blood present. She's 0 centimeters dilated with a cervix of 0% effacement. The remaining components of her exam were unremarkable. There's no evidence of hematuria, proteinuria, nitrates, or leukocyte on the urinalysis, and the oral glucose tolerance test revealed an elevated 1 hour glucose reading of 196 and an elevated 2 hour reading of 162. So those were her diagnostic results as well. And there's also no ketones. And her pH is normal and the color was normal as well. So based off of her diagnostics and her presenting symptoms, the most likely primary diagnosis is gestational diabetes mellitus. Other potential differentials, which are less likely, are urinary tract infection and diabetes insipidus. So her plan and course and disposition for this patient is she may return home with the below management. She can follow up in 2 weeks in the office with Dr. Lysa to review her glucose logs and monitor her symptoms. And she'll also receive a referral to a dietitian to help her implement a low glycemic index diet and give her insight on what foods to avoid and incorporate into her diet. So for her therapeutics and intervention, it will be lifestyle modifications by implementing a low glycemic index diet, encouraging moderate exercise as well, and to self-monitor her glucose. And pharmacological treatment will not be initiated at this time, but when she returns in 2 weeks, if her glucose is not at target levels, she will be initiated with insulin or metformin therapy. So for her patient education, she was educated that gestational diabetes occurs when the body does not produce enough insulin to manage the glucose in the blood, and she was informed that if GDM is not managed, there's an increased risk of having a larger baby, which can lead to delivery complications such as shoulder dystocia, preterm birth, or hypoglycemia in the newborn. She was informed of the importance of a low glycemic index diet, and which includes lean protein, vegetables, and whole grains, and to reduce sugary drinks and snacks. She was also encouraged to start light exercise and informed to monitor her glucose at home for her fasting, and then again for her 1 hour postprandial after lunch, and then again for her 1 hour postprandial after dinner. And upon follow-up, we will review her logs and assess for the need for insulin or metformin therapy. Her ER precautions were to present to the ER or labor and delivery with severe vaginal bleeding, leakage of fluid, decreased fetal movement, shortness of breath, chest pain, fever, severe pelvic pain, severe vomiting, dizziness, severe headache, vision changes, right upper quadrant pain, lightheadedness, or calf pain occurs. So in the United States, approximately 77% of pregnancies were complicated by diabetes of any type, with 86% of these cases being pregnancies complicated by GDM. Placental hormone release causes marked insulin resistance. Human placental lactogen is the primary hormone associated with increased insulin resistance. However, this hormone also increases insulin secretion and beta cell proliferation to regulate maternal hyperglycemia in normal pregnancies. However, in patients with DDM, maternal pancreatic beta cell dysfunction occurs or delayed release of beta cells. This results in decreased insulin secretion and ultimately leading to maternal hyperglycemia. Another factor that promotes abnormally increased insulin resistance is maternal obesity early in pregnancy, due to higher free fatty acid levels, which inhibits maternal glucose uptake and stimulates hepatic glucogenesis. So, some risk factors for gestational diabetes, as we talked about, is having an elevated BMI, decreased physical activity. There's certain ethnicities that are high risk, as well as any past medical history of GDM in the past, cardiovascular disease, hypertension, having a low HDL, triglyceride levels of greater than 250, PCOS, hemoglobin of greater than 5.7, or any significant markers of insulin resistance. So, management includes combining diet and exercise interventions, reduce the risks of large for gestational age infants. A reasonable approach is to start pharmacological therapy when more than 20% of glucose values are abnormal, or when there are more than five abnormal values in 7 days of careful monitoring. So, for this patient that we discussed earlier, we will monitor for that 20% abnormal values or more than five abnormal values in 7 days when she comes back for her next appointment. And if it is abnormal, we will start her on insulin or metformin. So, fetal monitoring for these patients, it is suggested to start at 32 weeks due to the increased risk of stillbirth. Surveillance once or twice a week is suggested for patients with poor glycemic control or who require medication. Fetal echoes at 18 to 22 weeks of gestation is also considered for these patients because there's a high risk of cardiac defects. So, for patients with GDM, it is often very common for them to have fetal microsomia babies, and it is recommended to discuss the risk and benefits of pre-labor cesarean delivery if the estimated fetal weight is more than 4,500 grams. Delivery during the 39th week of gestation may provide the best balance of maternal and fetal outcomes, and patients with GDM are 2 times more likely to have microsomic fetuses, including the risk of shoulder dystocia, brachial plexus injury, and cesarean delivery. Ultrasound biometry most recommended method is the most common and recommended method for estimating fetal growth, but it is only a 56% sensitivity in predicting microsomia, so serial ultrasound growth measurements are often performed. So this table on the left just shows the algorithm for early oral glucose tolerance tests between 6 to 12 weeks. And if the hemoglobin A1C is already elevated, greater than 6.5%, this is pre-existing diabetes and refer to high-risk obstetrics care. And if it's not, then you can diagnose the patient with early onset GDM. So, postpartum, following delivery, maternal glucose levels typically return to pre-pregnancy values. However, the risk of developing overt diabetes within 25 years is 10 times higher in patients who have a history of GDM compared to those who don't. ACOG and ADA recommend a 2-hour oral glucose tolerance test performed 4 to 12 weeks postpartum to screen for pre-existing abnormal glucose control. Breastfeeding may protect against future development of diabetes and should be encouraged. For patients with postpartum impaired glucose tolerance, treatment can reduce progression to type 2 diabetes. Intensive lifestyle modifications reduce the risk of diabetes over 10 years. So this is just a chart of after delivery, you can screen with either an oral glucose tolerance test or a hemoglobin A1C. And if it's abnormal, you can start with lifestyle modifications, patient nutrition counseling, and starting medications. But if it is normal, you want to screen for diabetes every 1 to 3 years. So our questions, we have a 36-year-old G3P2 who presents for a routine 37-week prenatal visit. The patient has well-controlled gestational diabetes. Her fetal ultrasound reveals an estimated fetal weight of 9 pounds and 2 ounces. Patient reports her other children were all vaginal deliveries and she would like to have a vaginal delivery with this child. What is the best recommended delivery method for this patient? The correct answer for this patient is C, to schedule for cesarean section at 39 weeks. D is not correct because there's an increased risk for shoulder dystocia with having a large baby, such as 9 pounds and 2 ounces. Magnesium sulfate for E is indicated for preeclampsia and eclampsia, but not gestational diabetes. You wouldn't induce labor at 37 weeks for this patient, and it wouldn't be recommended to continue pregnancy until 41 weeks because the baby's already at 9 pounds, as well as waiting that long has increased risk for um, low amniotic fluid and several other risks. A 36-year-old G4P3 with a history of gestational diabetes with her last pregnancy presents for a 12-week prenatal visit. Her fasting glucose results are 108 and her hemoglobin A1C is 6.2. What is the next best step of management for this patient? The correct answer for this patient is E, to perform an early 75-gram oral glucose tolerance test to evaluate for early gestational diabetes. Because she already is showing signs of diabetes with a hemoglobin A1C of 6.2% and an elevated glucose reading, it would be indicated to start to assess for early gestational diabetes in this patient. You um, you can refer to fetal maternal medicine specialists and potentially endocrinology, but that would not be the next best step for this patient. Wouldn't be indicated to wait until 24 to 28 weeks for her glucose tolerance test because she's already showing elevated signs of gestational diabetes. And metformin, you could begin metformin, but it's indicated to start with lifestyle modifications first, and as well as make sure that you're screening for gestational diabetes before starting any medications. A 29-year-old G2P1 with obesity presents with 36-week prenatal visit. The patient has gestational diabetes controlled with insulin. She reports decreased fetal movements, and her ultrasound reveals an estimated fetal weight of greater than 95th percentile, and her biophysical profile is 8 out of 10. What complication is most associated with poor glycemic control? As we have discussed, the correct answer is E for this patient. Babies that are microsomic often gain most of their weight in their chest and their shoulders, so the head will be delivered, but the shoulders have a harder time coming out and leading to shoulder dystocia, risk for brachial plexus, fractures, things like that. So that's the most common complication associated with poor glycemic control. These are my references. Thank you, and please let me know if you have any questions.